Good morning. Am I audible?
Yes,
Yeah,
Mansi,
you
you're
are.
audible and
Please go
visible.
ahead. Yeah.
Fine, good. I'm sharing my screen now. Good morning, everybody. It's a lovely Saturday morning, at least in Delhi. Unfortunately, I couldn't come for this conference, hopefully, with COVID, hopefully coming down maybe next year. So, thank you for the invite. Without further ado, I'll start. I'll be presenting the JCOG 1205 1206 study, which was a randomized phase 3 study of Irinotecan plus Cisplatin versus Etoposide plus Cisplatin for completely resected high-grade neuroendocrine carcinoma of the lung. This was published in JCO in November 2020. Now, as we know, small cell lung cancer is considered a highly chemo and a radiosensitive malignancy. However, not many patients are actually surgical candidates because it usually, presents with an advanced stage bulky nodal disease or with frequent systemic involvements. However, for those patients who have a very limited stage T1, T2, N0, M0, surgery followed by adjuvant chemotherapy is a considered standard of care. However, very few randomized data are available for this, although several retrospective and phase 2 single arm studies have shown a favorable outcome with this combination. So in spite of the above surgery and chemotherapy, the 5-year survival rate of even stage 1 SCLC is not that great. And this is an unmet need that we need to address further in how to improve further survival for these patients. So keeping in this context and also the fact that an extensive stage disease SCLC, Japanese phase 3 trial JCOG 9511 as well as a meta-analysis showed that the combination of cisplatin and irinotecan was better as opposed to the standard etoposide platinum cisplatin regimen. This was mostly seen in the Asian Japanese population, not really seen in the Western population, but still. Keeping this in mind, this multi-center open-label randomized phase 3 trial was conducted at 57 study sites in Japan, where they took patients with high-grade neuroendocrine carcinoma of the lung between 20 to 74 years of age with good performance status who had a pathological stage 1 to 3A disease after complete surgical resection and as well as the resection of any involved lymph nodes within 28 to 56 before enrollment. And they were randomized in a 1:1 ratio to either etoposide cisplatin, or irinotecan cisplatin. Etoposide was given at 100 mg per meter square day 1 to day 3. Cisplatin at 80 mg per meter square day 1 every 3 weekly for 4 cycles. And irinotecan cisplatin was given at 60 mg per meter square day 1, day 15, and cisplatin at 60 mg per meter square on day 1. This was a 4 weekly regimen, also given for 4 cycles. The patients were further followed up for survival and relapse. Radiation and PCI was not given in the study. A short point about high-grade neuroendocrine carcinoma. This included both SCLC as well as large cell neuroendocrine carcinoma, as well as those with combined histologies. That is either SCLC with LCNEC or SCLC or LCNEC with NSCLC components as well. So the primary endpoint to begin with was overall survival, and secondary endpoints for relapse-free survival, RFS, proportion of treatment completion, adverse events, serious adverse events, and second malignancies. However, in an amendment done in March 2019, the primary endpoint was switched from OS to RFS, as death events were too few to evaluate survival in the pooled population at the completion of patient accrual. The authors also mentioned at that time a meta-analysis had come out which showed that RFS may represent a valid surrogate endpoint for OS in studies of adjuvant chemotherapy for non-small cell lung cancer. So 221 patients were assigned, 1:1 ratio, and nearly 109 patients in each arm received chemotherapies. Point to be noted is that the proportion of treatment completion rate was significantly higher in the etoposide cisplatin arm than in the irinotecan cisplatin arm. That was 87% versus 73%. Coming to the baseline characteristics, they were well balanced. Most patients were male and smokers. The stage 1 patients were nearly 54% of the entire population, stage 2 around 30%, and stage 3 around 17%. The various high-grade neuroendocrine histologies were also equally divided between the two arms. The second interim analysis had a median follow-up time of 24 months. And as you can see in the KM curves, there was no significant survival difference, RFS difference in the 3 years RFS between the treatment arms. 65.4% in the EP arm versus 69% in the IP arm. Similarly, the 3-year OS was also not significant between the two arms. That was 84.1 and 79%. Also looking at the histologies, there was no difference in relapse-free survival between patients with SCLC or those patients with large cell neuroendocrine carcinoma. However, if you look at the stage-wise difference, you can see here that the RFS in patients with stage 1 was more when it came to irinotecan and cisplatin as opposed to etoposide and cisplatin, and this was the opposite in those patients with stage 2 to 3A. This is reflected in the forest plot as well. If you look at the subgroup analysis, another point to be noted is that those patients more than equal to 70 years of age seem to do better with the combination of etoposide and cisplatin. However, this is a very select patient population, so it's very difficult to comment on that. This is probably hypothesis generating. Coming to adverse events, so grade 3 and 4 neutropenia was definitely more in the etoposide cisplatin arm as opposed to the irinotecan arm. That is 97% versus 36%, and nearly 50% of the patients needed the use of growth factors in the etoposide cisplatin arm versus only 12% in the IP arm. Grade 3 for non-hematologic toxicities, that is laboratory findings, were also slightly higher in the cisplatin etoposide arm. Coming to the clinical adverse events, so grade 3 febrile neutropenia was nearly 20% in patients in the etoposide arm versus 4% in the irinotecan arm, and grade 3 for anorexia, diarrhea, fatigue, dehydration, they were more frequent in the irinotecan arm. So this is the first randomized phase 3 study that has evaluated adjuvant chemotherapy regimens in patients with completely resected high-grade neuroendocrine carcinoma of the lung. And it failed to show the superiority of irinotecan cisplatin over etoposide cisplatin for improving relapse-free survival. Point to be noted is that although there were more hematological toxicities with etoposide cisplatin, still these patients managed to complete the entire treatment at a higher percentage as opposed to those who received irinotecan cisplatin. Another observation would be that, it's not necessary that if you see benefit of a particular regimen in the metastatic setting, that may translate into a similar benefit in the adjuvant setting. So we need further research upon this. Although this is a rare select patient population, I mean, kudos to the authors for doing such a big phase 3 study to answer this important question in the curative setting. The 3-year OS was 80% in this study, but nearly 50% patients had brain metastasis on relapse. So the role of PCI in this particular setting also needs to be further defined, whether it will help in preventing further intracranial relapses or not. The trial only used cisplatin, which is the standard of care. However, what do we do about those patients who are ineligible for cisplatin, especially in the elderly? So these are some questions that we need to ponder upon. To conclude, I will say that the study did not find superiority of irinotecan cisplatin over etoposide cisplatin with respect to improving RFS in Japanese patients with completely resected high-grade neuroendocrine carcinoma of the lung. And EP remains the standard treatment modality for this population. IP can be used in select patient populations, so we have another option, especially in those patients when neutropenia might be of concern. As the study was stopped in between, follow-up period was immature at the second interim analysis. So follow-up data, including OS, may further confirm these initial findings. So we should wait for that. And another point is that, yes, RFS has been seen to be a good surrogate for overall survival in patients with NSCLC. Does that also, is that also applicable to patients with small cell lung cancer? Another thought to think about. The finding of differential efficacy of the regimens with the stage of disease is thought-provoking, but again, it needs further study and confirmation. And lastly, the role of surgery and adjuvant chemotherapy versus CTRT in a more limited stage of SCLC like 2B and 3A disease also needs to be better defined. So thank you.
Thank you, Dr.